All right, good afternoon, everyone. Thank you for being here. We are starting the budget hearing today for 4 budgets. Welcome to the Subcommittee on Health and Social Services. You may notice that some of us are not here today. We are actually also hearing, 3 of our members are hearing a jointly assigned bill, I believe in HGO, so they may be coming in at some point later. So we're down a few folks today, and I also understand that we are overlapping with a Senate Budget Committee hearing right now as well, so folks might be coming in and out. So as we know, it's a busy day in Annapolis, and we are getting down to brass tacks for finishing up on the budget, and so people will be coming in and out. We will just, for the budget order today, we will start with the Department of Disabilities, then the Department of Aging, the Maryland Department of Health's Health Regulatory Commissions, and then we will conclude with the Department of Health Administration budget, I believe. Yes, administration budget. So that's the order. We will start with the Department of Disabilities and the analysis report from our DLS analyst, Naomi Camaro.
Thank you, Mr. Chairman. My name is Naomi Camaro. I'm here with the Department of Legislative Services. I'm going to present the fiscal 24 allowance for the Department of Disabilities. The department's budget in the fiscal 24 allowance increases by 2.1% to $13.4 million, and it also includes one proposed deficiency for the 23 working appropriation of $88,000 in federal funding to support MD-TAP, which is the Maryland Technology Assistance Program. On page 3, Exhibit 1 shows the breakout of the 24 allowance. About a third of the budget is allocated to the the Telecommunications Access of Maryland program. Another about third, 36% of the budget, is allocated to personnel, and then 5% of the budget is allocated to the Developmental Disabilities Council, which is a federally funded program that operates a bit separately from the Department of Disabilities. Page 4 and 5, Exhibit 2, has the line item breakdown of the budget changes. I'm just going to point out a couple of items. On page 4, there's a reduction in assistive technology service equipment of $400,000 to align with pre-COVID-19 service levels. And then on page 5, near the top, there's an increase of $151,000 for the Senior Call Check program, which is administered by the Department of Aging and reimbursed by the Department of Disabilities through the Universal Services Trust Fund, which I'll speak about now. So that discussion begins on page 6. The Universal Services Trust Fund generates revenue through a 5-cent surcharge on telecommunications services across the state, and it pays for telecommunications for the TAM program, again, the Telecommunications Access of Maryland program, and the Senior Call Check program. Page 6 lists out the specific services and programs funded by the USTF, and the Department of Disabilities has noted in recent years that expenditures are expected to rise while revenue for the fund is expected to remain level. And so the 2022 Joint Chairman's report requested that the department submit an update on the status of the fund. And the department reported that it anticipates recommending an increase to the surcharge in fiscal 2029 to ensure that the fund remains solvent. I'm going to go through briefly the department's projections on expenditures and service usage over the next several fiscal years. On page 7, Exhibit 3 shows the anticipated usage of the TAM programs and projects that the usage of Maryland Relay Services is really where is going to be driving the rise in expenditures. Page 8, Exhibit 4, shows that the expenditures for the Maryland Relay Program are expected to reach $1.85 million in fiscal 27, and usage is also expected to rise particularly sharply between fiscal 24 and 25. The other program expected to have increases in usage is the Senior Call Check program. Again, this is administered by the Department of Aging. And Exhibit 5 on page 9 shows the projections provided by the Department of Aging for this program. Expenditures are anticipated to more than double between this period, and subscribers are anticipated to more than triple. Finally, Exhibit 6 on page 10 just shows the balance of the fund decreasing because expenditures are rising while revenue remains steady. But again, the Department of Disabilities does not think that there's going to be a shortfall of the fund until fiscal 2030. And so with that, I'll just conclude by saying that DLS concurs with the governor's allowance for the Department of Disabilities. And that concludes my presentation.
Thank you. Any questions for the analyst? Seeing none, let's bring up the department. Secretary Beatty and your team, please come on up.
Good afternoon.
Good afternoon. Please begin.
Chair Resnick and members of the subcommittee, I'm Carol Beatty. I'm the Secretary of the Maryland Department of Disabilities. And with me today is our Deputy Assistant Secretary, John Brennan. We also have some directors here who are available for any questions. I'm going to note that we have Lori Barong, who is our Executive Director of the Technology Assistance Program, and David Bahar, who is the Executive Director of the Telecommunications Access Maryland Program. And we also have some other staff that are available. I would like to thank our assigned analyst and for her very thorough analysis. Thank you so much for your thoroughness and your work with us throughout the last few months. We respectfully support the recommendation to concur with the governor's allowance, and this concludes my oral testimony, and we would be glad to answer any questions that you might have.
Thank you. Easiest budget of the session. Any questions? All right, seeing none, thank you very much. We do have one person signed up to testify from the public, so we'll bring them up now. Anil Lewis from the National Federation of the Blind. Okay, not here. Thank you. That concludes the budget hearing for the Department of Disabilities. We will now move on to the Department of Aging, and back to Naomi.
Thank you, Mr. Chairman. Pardon me. Again, my name is Naomi Camuro. I am now presenting the fiscal 24 allowance for the Department of Aging. So the Department of Aging's budget is proposes to grow by 9.6% to $88.8 million. Page 3 shows the breakdown of the fiscal 24 allowance in Exhibit 1. About 42% of the budget is allocated to programs required by the Older Americans Act, which includes ombudsman services, supplemental nutrition services, and $13.9 million of that is funded by federal stimulus funding. 11% of the budget is allocated to the senior care program, which I'm going to discuss in a moment in more detail. Exhibit 2 on page 4 and 5 has the line item breakdown of the budget changes. And I'll just point out that a major driver to the increase in the budget is due to the Department of Aging's spending down the federal stimulus funds. ARPA funding, American Rescue Plan Act funding, is going to expire at the end of federal fiscal 24, September of 2024. And so there's a larger chunk in the fiscal 24 budget for that. And then similarly, the funding from the coronavirus response and relief supplement, I believe it is CRSA, is going to expire September of this year. Page 6 and 7 has Exhibit 3, the Community Services Grant Program, has a list of community services funded by the department. I won't go through all of them, but just the total of that is $78.8 million going to community services for seniors in the state, which is an $8 million increase from the working appropriation. On the following page, page 8, looks at personnel. I did want to point out that as of December 31st, 2022, the department had 10 vacancies for a vacancy rate of 25%, and the Department of Legislative Services estimates that this vacancy rate would yield about $800,000 in savings, which is why we've asked the Department of Aging to comment on their recruitment efforts and how the department plans to spend its vacancy savings. Page 9 begins a discussion on wait lists in 3 community service programs: senior care, the Senior Assisted Living Subsidy, or SALS, and the Congregate Housing Services Program, or CHSP. Senior care is the largest. It's offered in all by all of the local area agencies on aging, which administer the Department of Aging's programs. And so it serves the most amount of people in Maryland. The department has had ongoing waitlists in recent years in these 3 programs, and so the fiscal 23 working appropriation included an enhancement so that the local AAAs could start to bring those waitlists down. And the 2022 JCR also requested periodic updates to understand what progress was being made on the waitlists. On page 11, Exhibit 8 shows the pattern of funding between fiscal 22 and the proposed 24 allowance. And so the fiscal 23 working appropriation increased the budget across these 3 programs by a total of $3 million. And in fiscal 24, the budget across all 3 has declined by $1 million from the fiscal 23 appropriation. In response to the JCR, the Department of Aging provided waitlist data from the local jurisdictions, as well as participation data in these 3 programs. And Exhibit 6 on page 12 shows that waitlists have actually increased in each of these 3 programs across all jurisdictions, and the amount of participants served by the programs have declined during this period. And sorry, I should have noted, this is between July 1st of 2022 and January 1st of 2023, so the first half of the fiscal 23 year. Exhibit 7 and 8 on page 13 and 14. Look at this, look at the waitlist and participant data in senior care and in SALS specifically, because those are the largest programs serving the most amount of people. And you can see that between 2019 and 2022, the waitlist to participant serve ratio has been quite high in recent years. Exhibit 9 on page 15 breaks down the senior care participation and waitlist data by jurisdiction. Again, senior care serves over 2,000 people annually, which is why we've decided to focus on this one. It's the largest program. All jurisdictions besides Queen Anne's County experienced decreases in participation during this period, this first 6 months of fiscal 23, and more than half of the jurisdictions experienced rises in their wait list sizes. I will point out, Upper Shore Aging actually managed to clear its wait list during this period. I think they had 12 individuals on the wait list that they were able to serve. Because of these trends, as well as the fact that the fiscal 24 allowance has decreased the budget slightly across these 3 programs, DLS is recommending adopting committee narrative, requesting an update on the waitlist and participation in these 3 programs in each jurisdiction, including how the Department of Aging is supporting the local AAAs to address the waitlists. The second issue I'll discuss just briefly has to do with federal stimulus funding. The Department of Aging has been awarded a total of $48.7 million in COVID-19 relief funding. Page 17, Exhibit 10, shows the 3 awards that it's been allocated money for over the past few fiscal years. And you can see that the 24 allowance includes $12 million of ARPA funding to spend down again before it expires at the end of September 2024. Exhibit 11 on page 18 shows the spending of SRSA funding, which is the funding that expires September of 2023 by jurisdiction. If you're looking at this in black and white, I apologize, but because it might be hard to tell. But most of the jurisdictions have spent down a majority of their funding. I think all told, 63% of the Supplemental Nutritional Award and 52% of the Vaccine Access Award has been spent down. Montgomery County and Baltimore City are the outliers, having not spent a majority of their funding as of December 2022. And so I'll close with DLS's 2 recommendations for the committees, both of which are to adopt committee narrative. First, requesting, again, an update on program participation and wait lists for those 3 impacted programs. And then the second is to request an update on the federal stimulus funding to ensure that the local area agencies on aging are able to spend down those funds ahead of the expiration. Thank you.
Thank you. I actually have a couple questions for the analysis. We'll go backwards. We'll start with the money by the AAAs for CRRSA funds. Do we know why Montgomery County still is holding on to so much money?
I don't know specifically from Montgomery County, but the Department of Aging did say that many jurisdictions might prioritize spending down other funds before using the federal stimulus funding.
Okay. And there are two programs that were created in the last few years. One is the Communities for Life that I'm seeing a 33% cut on. Do we have a reason for that?
No, I don't have a reason.
Okay. And where is the Durable Medical Goods Program? I don't see that. Is that level funded or is that?
That actually received an increase.
An increase. I missed that.
And it includes funding specifically to serve individuals with ALS. Okay. And I can find the exact amount for you.
Okay. We don't have to delay on that. We can figure that out. Great, thank you. Any additional questions? All right, seeing none, I'd like to bring up the department. Secretary Carmel Rokes. Did I do that right?
You did that right.
Awesome. And please bring up whoever from your department that you'd like to join you. Welcome, Madam Secretary.
Thank you.
Please begin whenever you're ready.
All right. So I am Carmel Roque. I am the Secretary of Aging for the state of Maryland for 23 days now. I have brought my team with me because they are better informed about the details of our budget than I am at this point. And I think that might be useful for everyone here. And my team includes Bernice Hutchinson, who is my deputy secretary. Next to her is Linda Weaver, who's my CFO. And next to her is Pam Seidel, who is my chief of staff. I also want to acknowledge that we have AAA directors present as well. And even though the AAA directors and employees are not part of the Department of Aging, they are the arm of the department that actually delivers directly programs and services to older adults and their families to improve their lives. And so we have Gina Valentine from Carroll County, Ophelia Ross-Ott from Howard County, Joelle Ridgway from Anne Arundel County, Aaron Bird from Cecil County, Yang Tan from Baltimore City, and Karen Winkowski from Harford County. I wanted to say that this being my first experience with government, I'm very proud to be able to serve the great state of Maryland in this role. And I am learning quickly about how the budget process works and all of the things that we need to do to be able to better serve people in Maryland. The things that have been lifted up as part of our analysis of the department's budget reflect the challenges that have been ongoing for some time and that we will consider priorities as we move forward in the years to come. In particular, the department is grossly understaffed because of the vacancies that we have, and therefore we are indeed struggling with meeting our statutory requirements. Likewise, our AAAs at the local level are struggling also with the vacancy levels and the turnover rates. We've already begun to do some things to address that, and this is an area where I will be prioritizing my time. There are also aspects of our mission as the Department of Aging that we have not executed on as fully as I would want us to. This goes beyond the direct programs and services that we are required to provide under the various statutes from both the federal level, Older Americans Act, but also the state level. And the area that we will be focusing on as well is to bring to Maryland an age-friendly focus and to begin to work with other departments and through other departments and other stakeholders to begin to position Maryland as a great place for people to live and age. And there's some very specific initiatives that we will undertake as we begin to do that work. There are positions vacant in my current budget that we can use to support that, as well as some of the funding that is still resting in our department as part of the COVID funds that have come through the last years. So with that note, I'm not really sure technically how I'm supposed to say we accept the findings and then ask if there are questions, but I guess that's where we are.
That sounds good. That was perfect. That's
Okay.
one of infinite ways to be able to say that. So thank you all very much. We appreciate you coming down. I do have a couple of questions that I actually posed to the analysts. So like I said, I noticed the two newest programs, Communities for Life budget is going down. The Durable Medical Goods Program budget went up a little bit. I think personally, both of those are going in the right direction, but I kind of wanted to get a sense of, where the budgeting came in on that and why that decision was made.
I don't have the exact answer for that, but I'm going to give you my opinion, and then perhaps my staff can fill in on the details. I'm very familiar with the Communities for Life program. When I was president and CEO of Keswick, former Secretary Kramer came to me and asked about helping to get this initiative underway. And Keswick, because it has an endowment that they could use for this kind of activity, stepped up to say, let's see if we can create this sort of new kind of program. I think we're at a point where we really need to do some analysis of the program, particularly through an equity lens, so that we can better understand who we're serving and how we're serving them. And I know that there were some efforts to build in some evaluation into the program and ways to capture data through the CRISP system, actually, the state system, to see whether we are actually impacting the end goal, which is to help people stay in their homes longer and safely and independently, and to try to reduce the flow of older adults from home settings into institutional care. So I am not sure about the details of how that amount was decided, but in my view, this is really take a deep dive and let's really look at that program. With durable medical equipment, my understanding is that after they were able to really stand up the framework for that program, it's been very effective in addressing the needs of people who fall through the cracks on the Medicare or Medicaid-based durable medical equipment system. And so with some additional communication and advertising, I think that program will likely grow and will continue to serve those individuals who currently really don't have adequate pathways to receiving medical equipment that can support their independent living. And that's all part of, let's help people stay home, let's help them be healthy, and let's prevent institutional care when we can. I hope that answered the question.
It definitely did. Thank you very much. I appreciate it. Any additional questions? All right, seeing none, thank you very much. We do have 5 people signed up to testify from the public. I'll call them up in 2 panels. So we'll start with Ann Seacott, representing the Maryland Association of Area Agencies on Aging. Say that 10 times fast. Carol Leinhart from the Maryland Senior Citizens Action Network, and Regan Vaughn from the Catholic Charities of Baltimore.
Mr. Chairman, members of the committee, how are you?
Please begin.
This feels very intimate. This is lovely. My name is Ann Seacott, and I am, I left my glasses over there. It's okay. Representing the, I can't say it 3 times as fast either, but yes, the Maryland Association on Area Agencies on Aging. Maybe a little faster than you. But just so that for folks that don't know, it is the association of the 19 AAAs, as we call them, that, as the Secretary said, deliver the services that the state funds. I do want to point out that the AAAs are very proud, thank you, of the fact that they are guided by the Federal Older Americans Act. And that's to provide services to people with the greatest needs, low income, minority individuals, individuals with limited English proficiency, and people who reside in rural areas. And I say that just to acknowledge that, when we talk about some of the programs like Communities for Life, what the AAAs want to do is be able to really focus their resources on some of the most needy people, and we're very appreciative to hear the Secretary talking about doing that as well through an equity lens. We are very supportive of the budget that has been introduced that includes some funding that was increased last year for senior care, for senior assisted living subsidies, for congregate housing. We're happy for the $1 million increase in the information and assistance program. This funding is very important because of the federal dollars that will be spent down. We do need to make sure that as the population of older adults increases, that we are mindful of that with these kinds of services. So with that, we want to say thank you again. We're looking forward to working with the Secretary as well as with the Secretary of the Health Department when we look at things like the Medicaid piece to how we're able to help keep older people in their homes. So thank you very much.
Thank you. Ms. Leinhardt.
Yes, thank you so much. My name is Carol Leinhardt, and I am the retired director of the Harford County Office on Aging, a past president of the Maryland Association of Area Agencies on Aging, and currently serve as the co-chair for the Maryland Senior Citizens Action Network, and for short, it's MSCAN. And you have my written testimony, and you're going to be thrilled to know that I'm not going to bore you by reading it. But I'd like to highlight a few things. And first is an absolute commendation for the area agencies on aging in the services that they deliver literally across the board to 1.4 million seniors. All those seniors would have access to information, to services from the Department of Aging or the local area agencies on aging. So we're very happy to commend them, and they have our undying gratitude. Now, I'd like to just give you a few highlights. And I think it's kind of sad to say that normally when people are looking at government spending on services, they really only worry about what it costs. And the Maryland Department of Aging is somewhat different because literally all of the programs that they offer are designed to save money. And they do that by keeping seniors as healthy as possible in the communities and avoiding, I'm going to say, outrageously expensive nursing home placements. And today, the annual cost of nursing home care on average is $108,258. And that is incredible to me. And here we have the senior care program, which is also designed to keep people out of nursing homes. And for a nursing home, the wait list we've talked about earlier generally has on average about 2,100 seniors waiting for services. And each year, about 150 seniors go to nursing homes before they are able to receive senior care services. And when I do the math on 150 seniors times the over 100,000 cost of nursing home care, just institutionalizing those 150 seniors costs the taxpayers $16 million. But we could serve the entire senior care waiting list of 2,100 people for $5 million. That means that we could save the taxpayers $11 million. So I think that's pretty amazing. On the other hand, the Congregate Housing Services Program, it's not really on the other hand, is another example of a program that saves money. It costs $3,000 a year to serve one Congregate Housing Services client. Nursing home costs today are $9,000 a month. And that means that we could serve 3 frail seniors for a whole year for what it costs for 1 month in a nursing home. So when you talk about bang for your buck, these programs really offer a big bang for the buck. And I think you can see that the money that's spent on the Maryland Department of Aging is not just money well spent. It's like an investment that gives big dividends. And I just want to tell you that MSCAN is honored to be able to come and testify before you today, and I thank you for the opportunity.
Thank you. And your comment about how we always measure costs and not the savings is my feeling about every fiscal note of every bill I've ever filed.
Amen.
Regan, please go ahead.
Mr. Chairman and members of the committee, my name is Regan Vaughn. I'm the Director of Advocacy for Catholic Charities of Baltimore. For 100 years, we've been serving Central and Western Maryland in a number of areas, including helping to seniors to age in place. We operate 24 senior communities in 5 different jurisdictions: Baltimore City, Baltimore County, Anne Arundel County, Harford County, and Garrett County. And offer the Congregate Housing Service Program at 7 of those sites. And then we have one other site that runs a similar program, but it's grant funded. And we've been operating congregate housing since the 90s, and I think I've been testifying in this committee about it for 14 years now, and just the importance of it. And Carol really talked about the savings. And we are really excited to have a secretary who has experience in the aging community and is going to bring that professional experience to the provision of services. With the Congregate Housing Services Program, we offer meals and light housekeeping to seniors living in our building so that they can stay in the building and not move to a higher level of care, whether it's assisted living or a nursing home, as Carol explained. And it is very cost effective, and the seniors pay into it. There is a subsidy that they have to pay into it, so it is not just state funded. The problem is with inflation and higher costs, if we want to increase our basket or even keep it the same in the Congregate Housing Services Program, we also have to raise costs on those seniors who aren't able to pay more. So then we're faced with a decision on what to offer in that packet. So we were disappointed to see that there is a cut in the Congregate Housing Services Program in the budget because the site left. Instead of reallocating those monies to the existing programs, they cut the funding from the budget. I think it was about $272,000 that would have gone a really long way for the seniors currently in the program. I also wanted to note on the wait list for Congregate Housing Services Program, you can only get on the wait list if you live in a building that offers the program. So if you live in a building that doesn't offer the program but would like to have those services, you're not counted in any type of wait list that we're keeping at the state level. And I think that's an important distinction when you're comparing it to the other AAA programs that are offered in the wait lists that are there. I noted in the Secretary's written testimony, she really wants to look at the regs around congregate housing, and we are excited to sit at the table to do that with her. We don't think they've been changed since the 90s, and the provision of services has changed so much since the 90s. We need updated regs, and we want to sit and work with the department to update those regs to make sure they're responsive, not just to the providers, but for those seniors that are participating in the program. So other than that small cut, we fully support the budget and really look forward to working with this administration and this department to really work to help low-income seniors age in place where they want to age in place. Thank you.
Wonderful. Thank you. Any questions for this panel? All right. Thank you very much. We're going to bring up the second panel. We have Tammy Bresnahan from AARP and Eric Colchamiro from the Alzheimer's Association. Okay, not seeing any of them. They also submitted written testimony.
Hi there.
Are you with Eric?
Yes, I am. I'm not Eric, but
With Eric, yes.
I'm Lynn Fan. I'm the advocacy manager for Alzheimer's Association. Wanted to see if I could read this testimony on Eric's behalf.
That should be fine. Thank you.
Perfect. Thank you so much. The Alzheimer's Association, representing the over 110,000 Marylanders with Alzheimer's and other forms of dementia, along with their caregivers, submit this testimony in appreciation of the work of the Maryland Department of Aging. We submit this testimony with 2 requests of this committee as it continues to budget process development. The first ask is a $21 million expansion of the senior care program to eliminate wait lists that exist at every county across the state and help more Marylanders age in place. The Maryland Department of Aging Senior Care Program provides resources for residents whose loved ones are 65 and older and at risk at nursing home placement. Countless individuals come to local aging departments seeking this aid. It could be used for services such as home care, medical adult day services, medication, and more. This program works. Local aging department reports that senior care recipients age in place for anywhere between 4 to 7 years, longer than non-recipients. Senior care saves money over costlier institutions, and it gives seniors more time with their loved ones. Yet there is a wait list in every county for the 2 to 3 hours of daily care these fund provides. The end result of this lack of resource for at-home care is that many Marylanders fester on wait lists, end up in nursing homes, or die without the necessary support. Support for this program will allow Marylanders to age in place. Local jurisdictions report that recipients live at home for over 4 years longer. And it will help our caregivers, including our 242,000 dementia caregivers who need a break. Because 68.8% of our dementia caregivers have chronic health conditions themselves, 27.7% have depression, and 13.6% are in poor physical health. This program helps. We urge the administration to provide a $21 million enhancements for this program as its supplemental budget, and if not, for this committee to use its authority to help Marylanders in need and eliminate these wait lists. The second ask is funding formula for local area agency of aging. The Alzheimer's Association, in its research across Maryland to develop legislation to aid dementia caregivers, has spoken with 19 AAAs. A consistent theme has arisen. Many do not like how the Maryland Department of Aging has been distributing funds to local jurisdictions based on a formula heavily weighted towards population. Some smaller jurisdictions feel disfranchised. The Alzheimer's Association has no position on how Maryland Department of Aging distributes its fund, yet we urge this agency, under the leadership of Secretary Rhodes, an experienced leader in senior and aging issues, to conduct an intensive outreach to the AAAs, listen, and consider a revised funding formula which truly leaves no one behind. And we would ask that more Miller's administration approach towards funding AAAs be detailed in Q4 of 2023 and a report to the budget committees. Thank you again for this time and consideration.
Thank you. Any questions for the witness? Seeing none, thank you very much.
Thank you.
That does conclude this budget hearing. A reminder to everyone that we also have a number of submitted pieces of written testimony as well from a number of organizations. So just be mindful of that and read that when you have the opportunity. We are now going to move on to the next budget hearing, which is the Department of Health Regulatory Commissions, and the report from our analyst, Ann Wagner.
Thank you very much, Mr. Chairman, members of the committee. As you said, I'm presenting the operating budget analysis for MDH's Health Regulatory Commissions. These are 3 independent offices within MDH, including the Maryland Healthcare Commission, the Health Services Cost Review Commission, or HSCRC, the Community Health Resources Commission, CHRC, And now the Prescription Drug Affordability Board is included in this analysis. On page 1, the fiscal 24 allowance provides $300 million almost entirely in special funds across these offices. The analysis breaks out the uncompensated care fund managed by HSCRC, as it is the largest source of special funds. And that fund is distributed to account for the care that hospitals provide that that the hospitals don't receive compensation for. On the next page, there's one item related to fiscal 23, and that's related to the Maryland Healthcare Commission. In last year's Joint Chairman's Report, the Budget Committees requested that MHCC conduct an independent analysis of the Behavioral Health Crisis Response System in anticipation of the new 988 crisis hotline launching. And so MHCC was asked to contract with a vendor for a needs assessment and to convene a work group that would inform this analysis. The Commission has not procured the vendor or began meeting with the work group, so MDH is asked to explain why there hasn't been progress on these requested activities. Moving on to the fiscal 24 allowance, Exhibit 1 on page 3 provides an overview of spending with 37% of the budget supporting the uncompensated care fund, as I mentioned. And then the next two largest sections of this budget are grant programs administered by the CHRC. And that includes the Consortium on Coordinated Community Supports and the Pathways to Health Equity, or the Health Equity Resource Communities funding. The next exhibit on page 4 looks at the other amount of spending in this budget. About half of that supports the administrative costs under the 4 units and the Maryland Primary Care Program. And then the other half supports additional grants and also operating expenses for CRISP, which is the state's designated health information exchange. On pages 5 and 6, the analysis includes the typical itemized list of changes between the working appropriation and the fiscal 24 allowance. Across the regulatory commissions, the budget increases by $36.5 million, and I'll actually jump ahead to page 7, which discusses the largest change. That is a $35 million increase for the Consortium on Coordinated Community Supports. And so this consortium was created in the Blueprint for Maryland's Future. It was meant to meet student behavioral health needs through community supports partnerships, and also to develop best practices for behavioral health and wraparound service delivery. And so since August 2022, the consortium has been meeting regularly, and the first annual report was issued in December of 2022. The consortium is also charged with implementing a grant program, so that's the main driver of the fund increase, as mandated funding for those grants increases from $50 million to $85 million in the allowance. A bill from last year altered the program slightly to have higher mandated funding levels starting in fiscal 24 and provided or required 2 additional regular positions to staff the consortium, and the allowance does provide those 2 new positions. MDH is asked to provide an update on issuing a call for proposals and distributing the consortium grants in fiscal 23. And at the bottom of page 7, moving on to a different grant program under CHRC, I'll highlight that that commission provides annual operating grants for certain safety net and community health programs. These grants, including operating expenses, are typically funded at about $8 million each year, and these were previously supported with funds from the Care First Premium Tax Credit exemption. The BRFA of 2021 changed the fund source for these grants by diverting funds from the assessment on health insurance providers under the Health Benefit Exchanges Reinsurance Program, but that was in fiscal 23 and 24 only. And so CHRC is set to continue administering the consortium grants and the Health Equity Resource Communities funding in later fiscal years, but we note in the analysis that the funding source for its operating grants is set to end after fiscal 24. And so after which the CHRC would need to compete for general funds or find another funding source to continue those operating grants. So then I will move on to the key observations section that begins on page 9. This first item discusses how the COVID-19 pandemic has affected Maryland hospitals' financial stability. And so under Maryland's unique all-payer hospital rate setting system, the HSCRC is charged with setting hospital rates. And since 2014, the rate structure shifted to setting certain population-based revenues in which HSCRC sets a global budget revenue for each hospital as a revenue target, and then hospitals then charge rates that add up to that target. In a response to last year's Joint Chairman's Report, HSCRC generally found that this financing model provided Maryland hospitals with much more financial stability during the pandemic than hospitals in other states. Exhibit 4 on the next page, on page 10, it illustrates the impact of COVID on hospital admissions. As you can see, in April 2020, they fell substantially. And that was due to the pause on elective procedures and just overall lower demand for the hospital services. And while revenues also fell sharply at that time, hospitals were able to increase their rates between certain set corridors and were able to bring their revenue back up and even above pandemic levels. And so HSCRC in its report did describe 2 potential added costs from the pandemic that could have impacted hospitals during that time. And so this included the unknown cost of treating COVID patients, as this was a new patient type. However, HSCRC sets rates in such a way that hospitals generally received enough to cover these costs as long as they didn't reach their global budget revenue targets. And then since all non-COVID admissions were down during this time, hospitals didn't end up running into that issue as they weren't hitting those global budget revenues. The other potential cost was more overhead needed to purchase personal protective equipment, prepare for surges, and then recruit and retain the hospital workforce during times of shortages. And so again, these costs were largely offset by the drop in other non-COVID-19 admissions. And then considering the uncertainty during this period, the federal government and HSCRC did make aid available to hospitals. At the federal level, this largely came through over $1.3 billion in financial assistance through the Provider Relief Fund. And so to account for this amount of assistance and revenue provided to hospitals, the HSCRC did take this funding into account for rate setting and offset global budget revenues by this federal funding. A few other actions that HSCRC immediately took was allowing hospitals to increase rates by a higher percentage than is normally permitted, and allowing hospitals to carry forward a portion of their global budget revenue into the following year. And so Exhibit 5 on page 12 shows how those 3 actions made up the difference in hospital global budget revenue shortfalls. And we note here that the undercharge carry forward and the corridor relief both have an impact by increasing provider rates, but then the offsetting federal provider relief fund has a negative impact on the rates, and so it prevented hospitals from having to increase them by having that offset in there. Exhibit 6 shows the relative hospital operating margins before and during the pandemic, and it shows that hospitals largely maintained their financial stability under this rate-setting system and even grew their operating margins in fiscal 21 slightly. And so MDH is asked to provide an update on fiscal 22 hospital operating margins and to comment on whether hospitals have continued to experience this overall financial stability in fiscal 23 year-to-date and more recently. And so I'll also note that there have been additional supports provided to hospitals during fiscal 23. It totaled $75 million, and that funding was provided mostly for workforce supports. And so HSCRC is also asked, MDH is also asked if that financial assistance will be taken into account in future rate setting. So I will move on to the second key observation that begins on page 14. This has to do with the Maryland total cost of care model, and that's a 10-year agreement with the federal government to improve population health, improve individual care outcomes, and control the total cost of care for Medicare beneficiaries. And so under this agreement, Maryland must meet certain Medicare savings targets. There are other targets outlined in Appendix 2, but I'll mainly focus on 2 of the cost-related targets. And I'll also note that Maryland has met all of its total cost of care model targets in calendar 2019 through 2021. And so turning to Exhibit 7, this chart shows the recent performance that Maryland has had on certain Medicare savings targets. Each year, the amount of Medicare savings should be increasing. It is different goals each year, and in calendar 22, I believe the goal is $267 million. But we will note that even though Maryland has surpassed these goals in the upcoming or in the immediately preceding years, in calendar 22, it's current because of increased Medicare costs in Maryland compared to nationally. It is expected that the savings will drop down to about $80 million and that target is currently not set to be met in calendar 22. The other target shown here is what's referred to as the guardrail test, and what that target requires is that Maryland's Medicare savings Medicare costs on a percent basis should not be increasing more than 1% above the national Medicare costs. And so again, in calendar 22, you are seeing that Maryland's per capita Medicare cost rate is at 4.37% compared to the national 1.8%. So currently in calendar 22, Maryland's not on target to meet these goals. And so HSCRC has proactively taken a few steps to lower Medicare costs moving forward. On page 16, these items are listed, the first being reducing all payer hospital rates. That took effect January of 2023. The second item is discounting Medicare payments. That action required federal approval that has been granted, and so it's expected to be implemented in March 23. The third item is increasing the public payer differential by 1% to reduce Medicare and Medicaid rates. And so this would be in fiscal 23 and 24 only. Again, this action would also require federal approval that has been received, and it's expected to start in April 2023, and that action is expected to provide $26 million in Medicare savings. And then the fourth item is reducing the Medicaid deficit assessment, which is imposed on hospitals. That action would reduce the Medicaid deficit assessment by $50 million, and that is currently shown in the allowance as the Budget Reconciliation and Financing Act, or BRFA, would reduce the Medicaid deficit assessment by $50 million and provide a backfill of $50 million in general funds. But I will note that action does require General Assembly approval, as it is part of the BRFA and part of the proposed allowance. Moving on to the next topic, as part of the total cost of care model, the state implements a Maryland primary care program, and that is a voluntary program that offers incentives for primary care providers who participate to deliver advanced primary care services. And so while those incentive payments are fully supported with federal funds, they do count against Maryland's Medicare spending totals. And so in the past few years, the department has been asked to provide reports on the cost efficacy and the results of the Maryland primary care program. Exhibit 8 on the bottom of page 17 shows the recent results of that, showing that the program has had a net increase in costs rather than a net decrease due to the savings it creates, or the decrease on total cost of care that it would create. And so MDH is asked to comment on potential changes to that program that might make it cost effective. And then DLS is also recommending narrative again this year to request continued reporting on the Maryland primary care program. Moving on to another item that was requested in that evaluation of the Maryland primary care program, the narrative from last year also requested that the department look at the racial diversity of the program. Exhibit 9 shows the most recent results, showing that among the Medicare beneficiaries participating in the program, overall they are slightly less racially diverse or more white than the general Medicare beneficiary population. And so that's what Exhibit 9 is presenting from that report. And I will note that this year's report did attempt to present data on the racial diversity of the providers participating in the program. That was a voluntary reporting request, and so only 36% of providers, or 183 practices, reported at least some of the data requested. And so the report did note, though, that diversity among physicians is a statewide and national issue, but there was some limited data reporting due to on that topic. And then finally, the last thing I'll touch on the total cost of care model is the population health improvement dimension of the model. And so Maryland has received approval to focus on 3 goals to improve population health. So that includes preventing diabetes, mitigating opioid overdose deaths, and then improving maternal and child health. And so through the Regional Partnership Catalyst Program, HSCRC is providing approximately $225 million over 5 years to groups that are focusing on these specific goals. I will highlight on the maternal and child health goal that from fiscal 22 to 25, that funding is being added to a special fund and provided to Medicaid and Prevention and Health Promotion Administration for those offices to provide grants and to certain programs supporting that goal of improving maternal and child health. And so that was estimated to be about $10 million each year for those efforts. I will note that allowance included an increase of $10 million under HSCRC as well for those efforts. And so MDH is asked to comment on how it will spend the $18 million budgeted across the department, and then particularly that increase of $10 million that was seen under HSCRC in fiscal 2024. And so the only thing left is on page 21 that provides the narrative or the recommended narrative requesting an evaluation of the Maryland Primary Care Program. But with that, I'll conclude the presentation. I'm happy to answer any questions.
Wonderful. Any questions for the analyst? All right, seeing none, we're going to bring up the departments. There's now a lot of you, so we might have to break this up and do it in two panels. So we'll start, we'll bring up the Secretary of the Department of Health, Secretary Scott, as well as Katie Wunderlich, the Executive Director of the HSCRC, and Ben Steffen, the Executive Director of the Maryland Healthcare Commission, and then we'll do the next tranche after that. Madam Secretary, welcome. Please begin.
Good afternoon, Chairman Resnick, members of the subcommittee, Laura Herrera Scott, Secretary of Health. Here with me today is Katie Wunderlich, Executive Director of the Health Services Cost Review Commission, and Ben Steffen, Executive Director of the Healthcare Commission. You'll hear from Mark Lechner in the next go-round, and then there's commission staff here available for questions as well. Ms. Wagner, as always, thank you and your team for their insightful analysis. I'm really just going to turn it over to Ben and Katie right now to answer questions and want to thank them both for all their work over the past year, and I'll answer any questions at the end specific to MDH.
Thank you. Good afternoon, Chair Resnick and members of the subcommittee. Thank you for having me here today. My name is Katie Wunderlich, and I'm the Executive Director of the Health Services Cost Review Commission. I want to start by thanking the analyst, Ms. Wagner, for her great report on the health regulatory commissions. There's a lot of information, as you heard, on the activities that all three commissions are doing. So I want to thank her for her work. I also want to acknowledge my colleagues, Xavier Colo and Mark Hoffman, who are here today to answer questions. So what I'd like to do, Mr. Chairman, is to just give you a little bit of brief overview about the Health Services Cost Review Commission and the model, and then respond specifically to the issues raised by the analyst. So as you know, the Health Services Cost Review Commission is an independent state agency. We are responsible for regulating the quality and cost of hospital services to ensure all Marylanders have access to high-value health care. Our primary responsibility and statutory duty is to establish rates for hospital services. So inpatient care, outpatient care that's provided at a hospital facility, emergency department care, and ancillary services. So we regulate all of those hospital-based services that a patient might receive at a hospital. That's our primary responsibility, but as the Maryland model has evolved over the years from a hospital-based all-payer model to a hospital and non-hospital total cost of care model, we have been tasked with helping to support the department and the state in developing and guiding the Maryland's total cost of care model, including transforming the healthcare delivery system, not just within hospitals, but across the healthcare spectrum. When I have an opportunity to talk about our model with members of the legislature and others, I really like to highlight some of the benefits that the state has accrued to Marylanders, specifically to this model. First and foremost, the model and the all-payer system that we have in place has helped to contain the growth of healthcare costs for all payers, not just Medicare, Medicaid, commercial, and the uninsured. So that is one of the primary benefits of the model, is that we have been able to contain the growth of healthcare costs for everyone across the board. There's a significant amount of equity built into our model through the coverage of uncompensated care. So patients that go to a hospital, or any patient, regardless of their payer type, is able to access hospital services across the state in their community, and collectively the state shares the burden and the financial cost of providing care to individuals that are uninsured or underinsured. We also, through this model, we invest in statewide, as the analyst mentioned, statewide population health goals around diabetes, behavioral health and opioid overdoses, and maternal and child health. We've prioritized health equity. Another thing I love to mention is we are the first state in the nation to have a health equity measure built into our hospital quality pay-for-performance programs. So hospitals, when they are rewarded and penalized on their quality, we have now in Maryland, we're the first in the nation to have a specific health equity and health disparity measure. And so we're really proud of that. The flexibility of the model allows us to add elements to our quality programs tailored specifically to our population. So I'm really proud of that. We're also developing a population health measure that we'll also be adding to our quality programs. Really proud of that work that we're doing with the field. We've also, the model includes significant involvement of our primary care workforce and our specialty care workforce, our primary care workforce through MDPCP, which we'll hear about, and our specialists through a program, a bundled payment program for specialists in Maryland. Just want to touch on a couple of things on some of the long-term stability that the model provides for Maryland hospitals. So under our global budget reimbursement system, which hospitals in Maryland operate under a population-based reimbursement system that drives value instead of volume, so it drives outcomes instead of additional patients coming in to see services. And that global budget aspect has provided a significant amount of stability to hospitals. Specifically through the COVID-19 pandemic, we've been able to provide flexibility to hospitals so that they could tailor their services and provide care to patients. It also provides a significant amount of stability to rural and safety net hospitals that have high cost and lower volumes. A couple of other things the analyst mentioned, the population health. We've funded regional partnerships that we're very proud of that span across the state, focused on diabetes prevention and management and behavioral health crisis services. So 2 of our statewide population health goals that we have provided rate-setting funds to hospitals. They were competitively awarded. They bring hospitals together that are in joint service areas and, importantly, bring in community-based organizations that they work with to reach patients where they are on the ground and to make improvements on those 2 areas. Then also, as the analyst mentioned, we do have the maternal and child health grant, which is provided to the department to advance progress on those 2 areas. We have taken proactive steps over the last year. In the reports, you'll see that our total cost of care financial performance has taken a dip in the last year, in calendar year 22. There are a number of reasons that dip happened, including very low national growth, and we are, as a state, compared to national growth. And so in 22, there was very low national growth. And so we did see a significant deterioration of our financial targets, but we took proactive steps before CMMI required us to. We knew that it was coming. We wanted to be responsible stewards. We wanted to responsibly spread out those reduction in payments across as much time as possible. So we took a number of steps, including reduced all payer rates, reduced Medicare payments, an increase to the public payer differential, and the Medicaid deficit assessment, which I do want to thank Governor Moore for including that 1-year reduction to the Medicaid deficit assessment in fiscal 24 as part of the package. So I do want to thank him and his team for that. So I thought maybe we could, I'll just respond to a few of the issues raised by the analysts. The first one that's specific to HSCRC are hospital margins. And we've provided some material to you all that you can peruse, but want to kind of highlight some of the margin data that we have provided. So just as a clarification, we evaluate hospital margins in two ways. The first is on regulated margins, which is income from services regulated by the HSCRC as a percent of total revenue. And so remember, those services are the hospital inpatient, outpatient, emergency department, and ancillary services that happen on a hospital campus. But there are also margins that we call total operating margins that include services and costs associated with businesses outside of that regulated entity. And the biggest driver of that is physician costs. So physician costs are the largest driver in the investments on the unregulated side, and what brings down the total margins. As you'll see in the paperwork that we've provided you, there are very healthy regulated margins. However, those are offset by unregulated losses, which bring down the total operating margin. We've presented it on a statewide basis and as on a median basis, so you can see the distribution of where hospitals' total operating margins occur. Another note about this data, through fiscal year 22 represents audited financial, so year-end audited financial data that's reported to the HSCRC. Fiscal year 23 is year-to-date, and those are unaudited, so those can change from month to month, but you can, the audited data through FY22 is final and submitted by the hospitals. The other question posed was whether or not the HSCRC planned to offset the $75 million in workforce support. We do not take into account that additional grant funding that hospitals received, the operating support that they've received to help them weather the costs, the additional costs of workforce. So we don't plan to offset that in the same way as we did the federal PRF funds. And the reason for that is that the federal PRF funds were specifically for losses, revenue losses related to COVID or additional COVID expenses. And so because the PRF funds were specific to revenue loss, that's why we included it in our calculations. The other item that was raised by the analyst is around the MDPCP program. We are very proud of the MDPCP program. It has come a long way. It has engaged and included coordinated primary care across the state. It is an investment in care transformation, and so I think it's important to note that there has not been a substantial return on investment yet, but it really is meant to be an investment in our population, in care transformation, in providing that advanced primary care that happens at the MDPCP programs and practices. The other thing to note is how the MDPCP program is run and administered. It is administered jointly by CMS and MDH, with CMS holding the final decision making on the elements. So to the extent that the state works with CMS to make changes to the program, and the state has worked with CMS to make significant changes, we've added payments for social determinants of health, a heart payment. There is an additional track which requires, which includes accountability for physicians. So it's important to note where the governance structure of the MDPCP program is. I think that concludes my remarks specific to the HSCRC, but I'd be happy to answer other questions as the hearing goes on, and we do concur with the recommendation in the analysis to provide an additional report on MDPCP. Thank you.
Wonderful, thank you. Mr. Steffen.
Thank you, Chair Resnick, Vice Chair Shetty, members of the committee. My name is Ben Steffen. I'm the Executive Director of the Maryland Healthcare Commission. With me today are several staff members from the MHCC, Richard Proctor, who's our Chief Operating Officer, Diana Dembeck, who's Director for Administration, and Tracy DeShields, who's Director for External Affairs and Policy Development. The Healthcare Commission has a very broad mandate. It includes making the health system in Maryland more affordable while making it more accountable, promoting equity, and increasing access. We do that through really, I'll give you 4 key words. We do that through planning, health planning. We do that through measurement and reporting on quality. We do that through an engagement of other stakeholders. And we do that through our functions as assessing policy options, oftentimes at the direction of the legislature, sometimes at the direction of the commission itself, and also very frequently in collaboration with our other state partners in the executive branch. You have a fairly extensive PowerPoint presentation included in your materials. I'm not going to go through that, but I would note that we are fully supportive and appreciate Governor Moore's allowance, as well as we are supportive of Ms. Wagner's assessment. I want to, first off, though, respond to her question on the fact that we had not done the behavioral health risk gap analysis. It's not because we have not paid attention to it. When we were assigned this, I did observe that we're most effective when we have a strong background experience in a topic area. Although we have authority over inpatient behavioral health planning, we're not well versed in outpatient and community-based services. Our first step was to meet colleagues in the department and talk about what they were doing in terms of moving forward, the progress they'd made in implementing the 988 program. And what we concluded is that programs were already underway, and it probably did not make a lot of sense to start basically back at square one to conduct a gap analysis when, in fact, BHA in particular had done considerable amounts of that legwork going forward. What we continue to the fall is to participate in various planning functions, as well as the bed registry work group that the secretary, along with the chair of HGO, convened, monitored that. And we came away with a couple of suggestions that we don't think the gap analysis is needed at this time. It may be appropriate that the Commission, working with colleagues, launch a evaluation of the progress in the program. Typically, evaluations today are done under a process called rapid cycle evaluation, in which results on evaluation of the project really feed back into the operation of the new project, so that it's not at the end of the program an assessment, but the evaluators provide information to the implementers during the implementation, so you can basically make some mid-course maneuvers, improve delivery of services. A second area that I think is missing is in the area of more fully engaging commercial insurers. Now, of course, the MCOs that participate with Medicaid, I believe, are well aware and engaged, but those individuals who purchase commercial insurance typically are not exposed to the availability of crisis-based services. And I think working with payers, the MHCC and others could perhaps bring greater engagement. There's greater awareness about the importance of assessing behavioral health crises. Oh my gosh, Ted Lasso had a behavioral health crisis right on TV. It's more accepted and appreciated that we need to address crises as they occur, rather than waiting for them to fester and lead to a long inpatient stay or something even worse. We're happy to commit to that, and we would be delighted to work with the subcommittee in thinking about ways that we could be more effective. A couple other points that I want to emphasize, consistent with Ms. Wunderlich's statements. We too are heavily engaged in primary care. We are leading a work group on primary care investment. the aim of which is to determine if the state should set a spending level for healthcare, total healthcare spending that would be devoted to primary care. We expect to release our first report in December of this year, and we look forward to working with the committee in thinking about how that would be implemented should the legislature determine that imposing a requirement that commercial insurers and perhaps Medicaid MCOs devote a certain amount of healthcare spending to the primary care delivery. I'll be happy to answer any questions. It is really a great opportunity to speak to all of you today and emphasize our commitment to supporting the broad new agenda moving forward. Thank you.
Thank you. Are there any questions for this panel? All right, seeing none, thank you very much. We're going to bring up the second half of the regulatory commissions. We will bring up the Honorable Ed Casemeyer, Mark Luckner, both from the Maryland Community Health Resources Commission, and our new regulatory agency on the block, Andrew York, from the Maryland Prescription Drug Affordability Board.
Thank you, Mr. Chair and fellow committee members, for letting us come today. My name is Ed Casemeyer. I'm chair of the Community Health Resources Commission, and with me is our executive director, Mark Luckner, who will be glad to answer all the questions I certainly probably couldn't. First, I want to thank the administration for its funding for our budget. It was gracious of them, and I want to thank Ann for her comments. And we do agree with all the comments that the analyst has to make. I do have one request I'll make at the end of my short statement. But first, I just want to go through a little bit about what we do. As you may know, that in the last couple of years, our responsibilities have increased significantly due to the legislation that you all have passed, and we are very happy that you've shown that kind of confidence in us to allow us to serve you to a greater extent. We have three fundamental programs that we utilize. First is our grants that we've given out for the last, since 2005, of $8 million that we provide to applicants who request grants for mostly medically underserved areas. That's our pride and joy, and we do that annually. Second, we have the Health Equity Research Community Act, that you passed most recently, whereby it's a more localized focus to help communities, and that we have a budget of $15 million for that program. And then most recently, within the Kerwin Commission, we have the consortium on community coordinated benefits, which basically means we're charged with providing behavioral health programs for all public school students in Maryland. That program is funded, excuse me, $50 million in 2023 and $85 million in 2024. Our consortium has been meeting since July, as Ann said. Delegate Rudolph is the chair of the consortium. They have 4 subcommittees that meet sometimes 1 or 2 times a week. We've had input from the public in terms of what they feel we should be doing. Our plan is to have our RFP ready by this spring and responses, and that by the beginning of the next school year, we should be offering programs in the school system. I just wanted to go back to our first program that I mentioned, the $8 million grant program that we've provided since 2005. We just are in the process of doing that right now, and usually every year we target a few areas for our applicants to target. Those are, this year, I think they're diabetes, maternal, child health, behavioral health, and dental care, which we hadn't done for a long while. This program goes back to 2005 when the CHRC began. As I said, just $8 million. It's come from a special fund and been mandated. Over the years, we've provided about 700 grants for about $120 million, and every jurisdiction in the state has utilized these, and we've served probably over 500,000 people since 2005. And most of this monies go to underserved areas with low-income people, and we really think it makes an impact. This year we had 55, I think, applicants, and we're only probably able to fund 20 to 21. One thing we're really proud of is that the grantees who have gotten the grants have been able to utilize our grants to leverage money in their communities. And because we try to provide the grants to those folks that we think can sustain these programs. And frankly, over 75% of our grantees, their program has continued. Even though our grants have run out, they're still in existence. And that brings me to the comment that I made earlier about making one request. Since 2005, our $8 million has come out of special funds and has been mandated. And as Ann mentioned, in 2025, the way things are right now, we would be general funded. And we really think that we've earned the respect of the legislature in terms of what we've done with this money has been very, very useful to an underserved a community that needs these funds. So our request would be that hopefully you can find resources to special fund this $8 million and that our grant be mandated throughout the future. So with that, I appreciate your attention, and Mark and I would be glad to try to respond to your questions.
Thank you, Senator. Mr. Luckner, do you have anything to add additionally? Or
he hit it out of the park. That's perfect.
Sounds good. Sounds good. Mr. York, welcome.
Thank you.
I believe this is your first budget hearing.
Our first one as an independent agency. Chair Resnick, thank you so much. Members of the subcommittee, my name is Andrew York, and I am the Executive Director of the Maryland Prescription Drug Affordability Board. We are an independent agency charged with making prescription drugs more affordable for Marylanders. We just want to thank the Governor's Office for putting this budget out. Thank you to Ms. Wagner for her wonderful analysis, wonderful and thoughtful analysis. We support this budget, and we are here for any questions that you have.
Perfect testimony. Thank you so much. Are there any questions for this panel? Seeing none, thank you all very much. We do have one person signed up to testify, Lori Doyle. I don't see her in the audience. All right, sounds good. There is written testimony, both from Ms. Doyle and others in the packets. So now we're going to move on to the final budget hearing of the day. We're going to move on to the Maryland Department of Health's administration budget. And bring up our analyst, Samantha Tapia.
Thank you, Mr. Chair and members of the committee. Again, I'm presenting on the Maryland Department of Health Administration budget. This includes a number of different offices. It has the Executive Direction Office, Operations, Hospital System Administration, IT Department, Office of Inspector General, and then the 11 institutions, the court-involved DDA and institution maintenance. So as the headline, we are looking at a total increase of $325.1 million, or 42.8%, to about $1.1 billion. And this is primarily driven by provider rate increases, which I will talk about, as well as, as a key observation, and then I will also talk about the opioid restitution fund. And then I'm going to quickly go over managing for results data and a variety of recommendations, some of them that are repeated from last year. So managing for results, looking at Exhibit 1 on page 5. on page 6 rather. Looking at resident on staff assaults, repeated issue from last year, resident on staff assaults per 1,000 patient hours. The goal being to have 1 per 1,000 hours. So the exhibit shows what that line is, the 45-degree line, that goal. Black squares are the fiscal 2021, and blue dots are fiscal 2022. Most institutions meet the goal with the exceptions of Eastern Shore and the 2 RECA institutions. Regardless of the goal rate, several institutions saw increases in assaults, including Spring Grove, Thomas B. Finan, and RECA Baltimore. So we've asked for commentary with any known reasons for these increases. And then repeated from last year was the committee narrative requesting a report on efforts to improve measures of patient and staff safety. So that is renewed in recommendation. The second managing for results issue is court-ordered placements. This begins on page 7. There's a mandate for timely admissions for IST and NCR patients that's incompetent to stand trial or not criminally responsible patients. They must be placed within 10 business days, and SUDS patients within 21 business days. So Exhibit 2 shows that the average admission time has not been met since the first year, and that time has been increasing each year since then. So we've renewed the request for a report on the reasons for this and efforts to improve placement times. Related to this, again, about NCR and IST patients, the MFR data on cost per patient shows that while the total number of patients has been decreasing from 2019 to 2022, costs have overall increased over the same period. So we've also asked for commentary on the reasons for this increase in per patient costs, in particular at the set in Potomac Center. All right. Moving back to the budget. Again, we are looking at a total of $325.1 million, or 42.8% increase to about $1.1 billion. And this is, again, driven by provider rate increases, $218.2 million in general funds, $195.2 million in federal funds. And this is partly offset by decreases in special funds from dedicated purpose accounts, totaling for the fiscal 2023 of around $121.5 million, mostly for workforce support. And then as a profile of budget spending, we have Exhibit 4 on page 10, showing a pie graph of the overall agency budget assignment. Provider rate increases take up about 38% at the $413.4 million. Then we have administrative operations and employees at 13%, or $142.4 million. Employees at 4%, the $48.3 million portion of that, which I state first before the state hospital system as a comparison. The employees for the state hospital system are 41% of the total budget at $443.1 million. And then we have the IT department and OIG at 1%. Zooming in on the administrative offices, this doesn't include the provider rate increases. We have about a quarter of the administrative budget dedicated to administrative support, about 27%. And this includes a wide array of operational functions like legal services, communications, human resources, and the budget management office. We have another quarter for the various offices, including the executive office, the various oversight offices, and IT at around 26%. Then we have Office of Capital Planning, which has a number of renovation projects scheduled or in planning for fiscal 2024. And then the Hospital System Administration, including that executive office, court-ordered evaluations, and secure transport. And then the last quarter, notably for the Opioid Operational Command Center and the Opioid Restitution Fund at 27%. Budget changes from the previous fiscal year. Again, largely driven by provider rate increases, but also by increased compensation for employees, including health benefits, the cost of living adjustment that we see across agencies, partly because of inflation. And then we can see the effects of inflation in the rest, in other increases, including in costs of food and other supplies at the various institutions. Other increases, as I mentioned, the renovations, just over 11 million, and then an increase in the ORF amount because of the Purdue Pharma settlement. So that's an increase of 4.8 million. And then 106 new contractual employees at about 7.1 million. And then again, the decrease is around 121.5 million from one-time grants in fiscal 2023 for Children's National Hospital Pediatric Cancer Research, grants to nursing homes and assisted living facilities, and assistance and workforce support for hospitals. The personnel, as I mentioned, 106 new contractual employees, 2.5 new regular positions in IT and human resources. But the 106 new contractual positions, 46 new security attendant positions to meet the guidelines of Chapter 572, 576 of 2020. Then 20 new positions, 9 for child and adolescent mental health, and a 9.5 for the patient worker program at Perkins. Then we have 13 new positions for the public health workforce program, and the rest administrative, including fiscal services and contract management. Vacancies are an issue. Vacancies as of December 31st were at 522.8, while the budgeted number of vacancies was at 378, or about 379. So this is 144 above turnover, leaving the vacancy rate at over 13%, 13.32%, above the budgeted rate of 9.65%. We have Exhibit 7 on page 16 that shows the lowest vacancy rates are in the highest staff programs. But there is a range of vacancy rates ranging from 5% to nearly 25%. We have renewed a request for a report on staffing and vacancies again. And then moving on to the key observations, looking at the provider rate increases and the related to the 15 minimum wage and the opioid restitution fund. So Chapter 10 of 2019 mandated yearly provider rate increases for behavioral health and Medicaid providers on a schedule working over the years 2019 through 2026. The Fair Wage Act of 2023, which is expected to pass, will accelerate these increases into the fiscal year 2024 to achieve a $15 an hour minimum wage starting October 1st of this calendar year 2023. Exhibit 8 provides a table on page 17, provides a table laying out the existing and accelerated rate increase schedules. So you can see the 2025 and 2026 rates moving into the fiscal year 2024 for a total of 12% for Medicaid and DDA providers, and then 11% for general behavioral health community providers. As introduced, the budget allocated sufficient funding based on the entire fiscal year, while the actual effective date of the $15 an hour minimum wage wouldn't be until October 1st, which this is over budget for the first quarter of the fiscal year. So we've recommended reducing the general and federal fund components of the provider rate increase by 25% to account for that over budgeted quarter. Then moving on to the Opioid Restitution Fund, Chapter 537 of 2019 established the Opioid Restitution Fund to receive incoming settlement funds from lawsuits related to the opioid epidemic. There have been some settlements and funds received into the ORF, and there are some lawsuits recently settled or expected to be settled. According to the MDH budget, the fund will include $29.6 million for the fiscal year 2024. But it's not clear what share of each settlement has gone to the ORF and any carryover of funds from year to year. So we have a recommended committee narrative to request a report on past, present, and anticipated future payments into the ORF and how settlements have been distributed to local and state government agencies since the ORF was established. Just reviewing recommended actions, and we have a couple that didn't have issue briefs in the analysis. We've requested a report on ongoing operational impacts resulting from the cybersecurity incident that took place December 2021. Then we have the 3 renewed report requests on staffing vacancies, the ISC NCR placement times issue, and patient and staff safety measures. Then we have the 25% reduction, the report on the ORF revenues and expenditures, and then a report on capacity and applications for admission to the 2 chronic care hospitals and the Hawley Center. And then with that, otherwise we concur with the governor's budget, and the rest of the analysis includes briefs on the past JCR requests and updates on a number of major IT projects that MDH is managing.
All right, thank you very much. Any questions for the analyst? Vice Chair Shetty.
Thank you, Mr. Chair. Thank you for this analysis. It's very comprehensive. I have a quick clarifying question. I note on page, I guess 1, of the executive summary, there's a much larger federal funds allotment for 2024. And I'm curious if that is entirely coming from the federal share for the accelerated provider rate increase, or if there's something else, and if that is anticipated to continue on, or if this will eventually potentially need to be replaced by general funds.
I know that the provider rate increase is probably almost
all of it.
All of it. Okay. I can follow up with anything else that.
Okay. Thank you.
Impressive, yeah.
Wonderful, thank you. Any other questions? All right, seeing none, let's bring up the department. Secretary Scott and your team.
Good afternoon.
Good afternoon. Secretary Scott, I also have on my, as agency representative, Special Secretary Emily Keller listed. Is she?
She's unable to join today, so
join.
Emily Brandenburg will address the questions for the OOCC.
Perfect. Thank you so much.
So with me today is Brian Morose, Acting Deputy Secretary of the Operations Administration, as well as Director of the MDH Healthcare System, and our Chief Financial Officer, Emily Brandenburg. I want to thank Ms. Tapia and the entire DLS Budget Analyst Health team for their insightful analysis. One of my top health priorities is to fill our vacancies, and this especially applies to our direct care workforce at MDH at our facilities. And before I go into a few more comments, if I can take a minute just to read a story. This came from a crisis stabilization policy paper, and Brian and the team have been working on all the continuum of care and the services that we need, and they're also referenced in this document. But this is the client that we're referring to. So Mr. Y is a 24-year-old man who was arrested at a convenience store on a Friday afternoon for eating multiple bananas without paying for them. When the clerk demanded payment, he refused and became increasingly argumentative, so the clerk called the police. The police officers found a disheveled young man standing in a corner clutching a banana that he pointed at the officers as if it were a weapon. He remained uncooperative and illogical, yelling that the store clerk and the police were in the plot and out to get him. He became combative when police attempted to handcuff him and had a blunt marijuana in his possession. When the officers reviewed his record, they noted 2 recent previous calls, one for a similar incident and another for vagrancy. On both occasions, he was given warnings. This time he was arrested and taken to the local jail where he remained agitated, uncooperative, disorganized during the booking process, and during a night in jail screaming so loudly he had to be moved into a solitary cell where he has spent the weekend crying and yelling that he was being tortured. When taken before the judge on Monday morning, he was more agitated than the previous day and was hoarsely shouting nearly incomprehensible things about the judge and public defender conspiring against him with demons. The judge was concerned he was not competent to stand trial on charges including theft, resisting arrest, assaulting an officer with a banana, and marijuana possession, and ordered a competency evaluation. Mr. Y remained in jail for several months, waiting for the completion of the evaluations. 6 months later, 2 evaluators determined that Mr. Y was not competent to stand trial. The following month, the judge adjudicated him incompetent and ordered the State Human Services Agency to send Mr. Y to a state psychiatric facility for restoration of competency. Since there was no available beds at the restoration facility, Mr. Y remained in jail at an additional 6 months until a bed became available. After 3 months of the restoration facility, he began to take medication and started his competency restoration classes. 3 months later, the doctors at the facility determined his competency had been restored and sent him back to the local jail for trial. While waiting there for 60 days, the county jail had a different drug formulary, changed his medications, and he stopped taking his medicines. As a result, he was returned to court, decompensated in court, and was subsequently found again to be incompetent. And this was written in a health policy paper, but these are the clients that we're talking about when we're talking about our wait lists and some of the reasons why they exist. So I just wanted to share that story just to give some context. And working with Brian, I have been doing a deep dive over the past 4 weeks into the issue, and we've met with the judiciary, including Chief Justice Fader and Chief Justice Morrissey of the District Court. In addition, I have regular bi-weekly meetings with Chief Judge Morrissey to work through some of these issues. It is important to note that 99% of our patients in the 1,056 psychiatric beds are court-ordered individuals, and that we have a similar size waiting list for patients to be discharged as we do for individuals to admit. Discharges are often harder than some of the admissions. 2022, we received 865 court orders, 126 more than 2021, the most in 5 years. Because our facilities operate at full capacity, admissions are dependent on discharge. We have been systematically working with community providers to strengthen our capacity so they can accept patient discharges. We are also working with jail wardens to ensure that we admit based on the date of the court order and address those in the most clinical need. I'll turn it over to Brian to be more responsive to the DLS questions, but I did want to set the stage just how complex this is and the work that we're already starting to do outside of MDH.
Thank you. Good afternoon. I'm Brian Morose. I'm the director of the MDH Healthcare System and the acting Deputy Secretary of Operations. As noted by the Secretary, we are focused on reducing our court-ordered wait list and our cycle time, and that is our top priority. We take seriously the legislative mandate to admit the individuals within 10 business days of court orders, and prior to the pandemic, we were meeting that mandate. Ongoing complications due to COVID and the unprecedented amount of court orders have affected our admission times, so we took action and we took a number of measures to adjust. As detailed in our company report, we took a number of actions since April 2021. We've opened capacity in our state healthcare system by 43 beds. Those beds are at Eastern Shore. Those increased beds are at Eastern Shore, Springfield, and Spring Grove Hospital. We identified community bed capacity and addressed barriers in discharging patients from our hospitals to those beds. What did we do? We provided emergency staffing assistance. We recruited additional state discharge coordinators. We dedicated funds to community assisted living programs and opened up 40 beds in the community. And we pursued non-traditional process improvements like expanding housing placements for discharged patients and legal services for discharging undocumented patients. So I'd like to go on to the responses, the analyst responses. To the first DLS prompt, we will review our managing for results, data submissions to ensure data integrity. We have added an additional audit mechanism to going forward. Our new MDH Healthcare System CFO, Chief Financial Officer, will work with the facilities to verify the data before it's submitted. We have been working with the DLS analysts on correcting some of our facilities' data, as for Perkins, such as for Perkins and for Finance Center. As noted before, there has been an increase in incidents because of the increased court-ordered admissions we've been getting, along with the types of clinical cases that we're seeing. We've also been working towards removing barriers to facilitate the discharge of patients who are ready to go to a less restrictive care. So overall, patient populations have been more acute in the system. We are closely monitoring that data and will be happy to provide more details as it is analyzed and reported out. As such, we concur with the request for a report on patient safety at the MDH facility. We also concur with the request for a report on the time and placement of court-ordered patients and efforts to improve placement times. And we did submit a report on Tuesday, February 21st of 2023. We are happy to supplement this report later this year with an update. As to the costs at the set, due to increased cost per patient in FY22, this appears to be due to various employee salary increases and incentives and a decrease in average daily population. The increased acuity of these residents admitted had an impact on our increased need for staffing. We also concur with the request for reporting on staffing comparisons. This analysis is critical to support our efforts to reduce vacancies, especially positions which face high vacancy rates and frequent staff turnovers. We ask for a due date change from August 1st to December 15th to allow us to evaluate the impact of the annual salary reviews that will take effect July 1st. As for rate reductions, the department is in discussions with DBM to update the allowances so that it reflects the new start date of October 1st, 2023 for fast-track provider rate increases. I will now turn it over to Emily.
As our secretary mentioned earlier, Special Secretary for Opioid Response could not be here today because of a scheduling conflict. However, this department does concur with the requested report on past, present, and anticipated future payments into the Opioid Restitution Fund and payment distribution. In addition, the current balance of this fund is $46.8 million. The OOCC has provided additional information on currently awarded ORF funds in our written response, and we will be happy to take any questions back on our opioid response colleagues and follow up with you in writing. And this panel is available for questions as well. Thank you.
Any questions for the panel? Delegate Heinbaum.
Thank you, Mr. Chairman. Madam Secretary, the story you read, excuse me, what can you do to get to those people before they spend? That fellow sounds like he had 1.5 years or 2 years in jail. What kind of things can we do to identify those people to get them the help they need rather than let them sit in jail for 6 months?
So that's something that we're working on now. We are doing a full inventory of, if we think about, or the way I'm thinking about behavioral health as a continuum of care, thinking about prevention, primary behavioral health, urgent care, which is the crisis 988 mobile crisis units, and then acute care. What are the resources we have in the state and where are they? And then figuring out what more do we need. In addition is how do we, thinking about mobile crisis response teams, how do we, in the case of that gentleman, instead of calling the police, or even when the police are called, instead of the police taking action, a mobile crisis response, it was clear that the gentleman was maybe not alert and oriented ×3, especially as he was pointing the banana at the police officer. So those are some of them. It's just what's the delivery system to take care of a client like that. But the other is once they are in the system, how do we work with the judiciary and the prison/jails to treat those clients differently, to make sure they are getting the care that they need so they're not in these waiting periods for as long as they are. As I've mentioned, just in the 4 weeks I've been here, we've met with Chief Justice Morrissey and Chief Justice Fader, joined the discussion. I'm going to some of the courts just to see the mental health court and the veteran court just to see how they're operating and the case management services. But we are trying to connect the dots, Brian and I, with the judiciary, with the jails and prisons to see how, at least among ourselves, we can shorten those times so those clients can get the care that they need. So the work is just starting, but that's the work that has started.
So, but in that case, did it break down at the local level? I mean, should there have been somebody locally that identified that as an issue? There isn't like a hotline that a sheriff's office can call and report a situation like that, is there?
This was a generic story. I don't know what jurisdiction it was. It's not a Maryland story, but it's clients in Maryland have stories like this.
Thank you. Thank you, Mr. Chairman.
I'd like to follow up with a couple questions as well. The chart that we saw in the analysis based on assaults, the analyst referenced legislation we passed a few years ago that required minimum security staff within state facilities. By the sound of it, sounds like we've got some hiring being done in that department, which is great. We had a disagreement with the previous administration about how we interpret that legislation and the number of staff that was required on a floor at a time at any given time. So it sounds like you're building up, but what is your interpretation of the staffing needs for security personnel in state hospitals, and how are we filling out those personnel positions?
Yeah, I can answer some of those. Okay. I can answer some of those. So we did an analysis, and we felt that we were meeting the law as it was presented, so we've met those ratios, but we're constantly evaluating the safety of our patients and our staff ratios, whether it's mandated or not. We want to meet the mandate, but if it needs more, then we want to do more. So we're constantly looking at our security force, but also our treatment teams and our direct care staff. There's a lot of staff that are working very hard out there every day for these patients and deserve a lot of credit. So I always want to give them a lot, but we're constantly evaluating those staff ratios.
Okay.
And as was mentioned, the acuity of the patients is increasing, so then the staffing ratios are increased to match the acuity of the patients on the floor.
Yeah. Great. Wonderful. And then my second question, more of a capital question, may not necessarily be appropriate for here, but Chairman's prerogative. Last year, I think it was last year, the department submitted a capital master plan for the department. The Appropriations Committee felt that it would be inappropriate for us to pass a capital master plan in the last year of an administration and saddle a new administration with that plan without their input. So we did our best through using our budgetary tools to slow that process down. So now that you all are in and have had the opportunity potentially to have at least looked at that plan to move forward, can you tell me what the status of that is? Are you reevaluating? Are you moving forward with what was presented?
Thank you for that. And yes, part of the plan is built in that we review the plan every 3 years to make sure it's meeting the needs of the community and our population. So we're under that next set of review to come up to see if it matches the changes that have already occurred. And there's already been changes that have occurred due to COVID and due to what we've already addressed here with increased court orders. So we know there'll be changes to that plan. And I don't have them ready to present today, but we are reviewing them.
Well, and just to be specific, there will be resources needed to expand some of the facilities to meet the demands for the beds, and other facilities maybe not. So we've gone through the plan once, and to some of the bed capacity issues, there is some brick and mortar work that's going to be needed for in the short term to expand some beds. But then, to Brian's point, we're looking at all the facilities.
Sounds good. Delegate McCaskill, you had a...
I do. I just have a follow-up question from Delegate Heinbach. Back to the story. Thank you for sharing it, and it is good to hear that you all are thinking forward on a lot of the crises. But what could have been done different if instead of the police being called, perhaps, or the police identifying that maybe a crisis intervention team perhaps need to be called, but if the hospitals don't have a capacity for them, wouldn't that person, I'm sure that story is widespread probably throughout the state, but wouldn't that person probably still end in the prison system?
So I don't know the answer to that. Again, the story wasn't specific to Maryland,
Okay.
and that's why we're doing the inventory now, just to
Okay.
see where are all the ways that a client like that enters the system, and then how do they ultimately end up in the police versus treatment for what's obviously a mental health or behavioral health issue that needs to be addressed. So that's work that we're just starting. Brian and his team are pulling together all the information, and so I don't have an answer for you today, but that's one of the questions that we're trying to answer.
That's good to hear. Thank you.
Sure.
Any additional questions? All right, seeing none, thank you all very much. We do have one person, no, I'm sorry. We have 4 people signed up to testify, so we'll call them up now. Sharonda Huffman from the Maryland Inclusive Housing. You testified yesterday. She might have accidentally signed up twice. All right, we'll bring up Denise Gilmore from AFSCME, Serena Hopkins from AFSCME, and Jackie Caldwell from AFSCME. Please go ahead.
Good afternoon. My name is Jenny Reese. I am a member of AFSCME Local 539 and a licensed practical nurse at Springfield Hospital Center. All across the state of Maryland, staffing shortages are taking their toll. With these shortages come mandates, overworked employees, and even more hazards on the job. In our hospitals, this is directly affecting patient care. Without continuity of care, patients admitted into our psychiatric facilities that are in crisis are unable to develop therapeutic relationships. Every face is different. Staff pulled in from different units, even different facilities. This is scary. These patients do not know if they can trust someone that they have just met. This is a complete disservice to them and our staff. High acuity units especially should operate with consistent treatment team members and trained security attendants, all prepared to act accordingly in times of escalation. Early intervention is key. It is when no one is familiar with the patient that early signs are missed. Unfortunately, we have seen the result to be patient-to-patient and patient-to-staff assaults. At facilities recently classified court-involved, security attendants have received modified training. After being told they would go through the correctional academy alongside correctional officers, the decision was made to do the modified training. This decision was negligent and downright dangerous. The majority of patients admitted are coming directly from jail under the Department of Corrections for further evaluation. Yet our officers are being denied adequate training. The assaults continue. We have had staff and patients choked, tackled, bitten, assaulted, resulting in fractured orbital sockets, kicked in the face. We even had 3 officers sent out 911 from one single incident. While I thank you for your previous support in getting pay parity across forensic facilities, we would appreciate your continued support to push for parity with our retirements as well. If all facilities had 20-year retirements, such as Clifton T. Perkins does, we would be able to retain our staff, hire more, and allow us to provide better patient care. This is why I sit here before you today. We need your help. We need to address the staffing shortage and safety concerns at hand in order to better serve the state of Maryland. Thank you.
My name is Serena Hopkins. I'm currently a SA at Clifton T. Perkins, security attendant at Clifton T. Perkins. I'm here to talk about the training that we lost. Since 1980, Perkins was going to Correctional Officer Academy, and then in 2020, it was stopped. Clifton T. Perkins is a maximum security forensic facility, which we transport our patients as far as Hagerstown, Cumberland, and Eastern Shore. None of our new staff are trained on how to transport. They just come in and they work, and we tell them how to put on restraints, and sometimes they're not properly put on, which leads to more assaults and also a chance of them escaping in public. Sometimes we go to the hospital. Recently, we had a patient go out. It took 9 sheriff department officers to help us put them back into a van, and that was because her restraints wasn't on properly due to a new officer taking her out. She was able to slip through her handcuffs, and it caused a situation in the courthouse. Also, as far as we have more of abundance narcotics coming into Clifton T. Perkins at this time because we have DOC inmates that's only coming in for evaluation. None of our staff are trained on how to identify those type of narcotics. We have had Suboxone come in abundance, and no one is talking about it. That's all I have. So to ask that we get the proper training for our staff so that they can be more vigilant and so that that will lower the chance of escape. Thank you.
Thank you. Any questions for this panel? All right, seeing none, thank you all very much. Appreciate everyone's time. We are going to have, I believe, 3 sets of budget hearings next week in this subcommittee, and then we will be done with all of our budget hearings. So we have a busy week next week, and then on to decisions the following week. So thank you all very much, and we're adjourned.